and we got everybody that was currently living with HIV on antiretroviral therapies or ARVs and connected to resources and remained in care and virally suppressed, we could actually end the HIV epidemic.
Hello there. I am so excited because we have a super special guest today, Dr. Marissa Robinson. It will be a different type of episode because typically we'll talk to physicians or dentists, but you are a doctor of public health. So I'm so excited to hear about your journey and your passions. So I want to know if you can tell us a little bit about yourself and your journey to public health.
Absolutely. So thank you so much to Dr. Erkeda for inviting me. I've been a big fan of the podcast and of you. And it's so funny because I actually saw you presenting at a health equity conference. And I said, oh, I have absolutely got to put myself out there and reach out to you on LinkedIn. And it's so beautiful how our friendship has now blossomed into, a collaboration. So super excited to be here. Yes, I am a doctor of public health. The journey has been long and it is not over. But after, a number of years of being in school, I knew that public health was something that I wanted to do. I started out as a chemistry major. I thought I was going to be a physician. And then at Spelman College, that just was not my ministry. And so being a social butterfly was what I knew best. And so I switched to the social sciences and psychology. And then I double minored in environmental and public health. But public health was really where I got to see all of my different disciplines come together in this coalesced, beautiful picture. So I had medicine, I had science, I had research, I had community, I had, being a Black woman, I had identity and racial and health equity and social justice, all in this beautiful field of public health. And so over the course of my trajectory from Spelman, I then took 3 gap years, was a Peace Corps volunteer, and then came back to the US and said, you know what, public health really is for me. Started working in the federal government in infectious disease work and HIV work, and got my master's in public health at Emory University. And then right after I graduated from Emory, I started at Morgan State University for my doctorate of public health and graduated this past December, which is so crazy to think of how long I've been in school, but also just how beautiful this journey has been. And everybody who's in public health, their journey is very different. And anything that you look at in life can be associated to public health. So I'm super excited to dive into all of the things today with you.
I love your story, and I love that you highlighted how originally you thought you were going into medicine, but then you figured out hey, this isn't necessarily my ministry. It ain't for me. But let me figure out what is best for me. And I think that that's important because we have a lot of pre-med listeners out there. And one of the things that I tell them is if there's absolutely anything that you can think about that you're driving towards or you can consider doing aside from doing medicine, try that first. If you want to be a doctor, come back like a medical doctor, because there are so many ways to help people, and a lot of people's passions, yes, we are a service-oriented field, but there's so many different ways to serve. You can be a nurse, you can work in public health, you can work in an admissions office, you can work for the government, and all of these different ways to help people. So there are many ways to skin a cat. It doesn't necessarily have to be in a clinical room or a surgical suite. So do some deep diving and kind of figuring out what you want to do, because the journey is long and it's hard. So it should be something that you are passionate about.
Yeah, absolutely. And not only you're passionate about, but something that is unique to you. I always tell students and mentees of mine that nobody can take away your education and nobody can take away your passion. And specifically when entering into a PhD or a DRPH program, you have to choose something called a dissertation topic, usually what you're going to study, or you're joining a lab or doing a specific area of research. And when you're diving into figuring out what are you passionate about, and what can you be passionate about for more than 4 to 7 years, I think my biggest thing that helped me kind of hone in on that was that my identity as a cisgender heterosexual Black woman was super important to the work that I do currently in infectious disease. And there's not a lot of people that look like me that are in this field. And specifically at the federal level, which I'm sure we're going to talk about a little later, is that I was seeing certain gaps in the data and the research and the areas in which we were focusing on at a national level. And so I took all of those different experiences and created this concept of, let me look into this population of women and see if I can help bridge the gap and or add to the body of knowledge of research that is out there. Because we all have a story. We all have a contribution to medicine, science, public health. But truly, as women of color, we carry a bigger burden of, if not when, how, and if not now, when. So I think that really kind of motivated me to stay in this field of research and focus on Black women. And I encourage those that are in thinking about pre-medicine or thinking about, hey, what is public health? How can I get it more involved? If you're thinking about going into law school and figuring out how can you tie in medicine, think about environmental justice and public health justice. There are so many different ways that public health can intersect with medicine, sciences. And even if you don't go to med school, it's okay. Even if you want to be a physician's assistant, even if you want to be a nurse practitioner, even if you want to be a pharm tech, if you want to be a pharmacist, if you want to be a public health practitioner, there is a place for everybody. And I think in academia, we put ourselves in these like really neat boxes of like, I have to check a box or I have to, achieve this goal in order to get into this school. But sometimes as a unique individual, we don't fit into boxes. Mm-hmm. And I'm all about thinking outside the box and breaking barriers and breaking stereotypes. So I think as a people, we have to start thinking innovatively and differently to academia and schooling and how we can all make a difference because everybody has a role.
I love that. And I definitely agree that everyone has their own journey. And it may lead you to different places. Even if you are considering, like most of our listeners, MD, you may want to add something. Like you said, JD, you may want to add a master's of public health. You may want to get a PhD. So there are a lot of programs out there. If you add those into them, they're actually paid for it, which can also be beneficial. And then figuring out how you will navigate that. So I wouldn't recommend just getting degrees to get degrees, although some people do that. I know.
Right. Don't recommend
it. But like figuring out what you would do and how it will shape you. Because I know a lot of students will enter medical school and they'll say, I'm going to get an MD, PhD. Why? What do you want to contribute to it? What do you want your dissertation to be? How do you want to influence the population after you leave is very important. So I want us to kind of talk a little bit about what your dissertation was and what your research is in, so that we can see a little bit more about if there are any interests out there or how the field and the realm is.
Absolutely. So again, I graduated from the Morgan State University, and my dissertation it's a long and lengthy title. It's a qualitative exploration of pre-exposure prophylaxis, or PrEP, among Black women attending a historically Black college and university in the Northeastern United States. So I basically looked at a qualitative study, which if we think about quantitative and qualitative, for the folks that aren't familiar with quantitative is something that you can quantify. So usually it's math related. It's usually an amount of numbers and doesn't really go into the descriptives. Descriptive statistics is what you can capture within qualitative data. And this is where you can get stories being told. You can get different anecdotal things like quotes and do things like focus group interviews or in-depth interviews that are one-on-one. And qualitative, I think historically has not been as revered as quantitative data, especially in sciences and medicine. We focus on the quantity of diseases, or we focus on how many individuals are impacted by a specific health disparity. We look at prevalence, which is how much of a disease exists, or we look at incidence, which are new rates of infection or a new rate of a disease. And so with qualitative, we get into the how and the why, right? Because a lot of times with data, it's just one point and you think, okay, this is a data point. But with qualitative data, we get to take a deeper dive into the how and the why somebody might fall into a certain category. So my research looked at talking to Black women that were current students and their thoughts, knowledge, and attitudes and perceptions of this medication called pre-exposure prophylaxis, or PrEP. And so for those that don't know, PrEP is 99% effective in preventing HIV acquisition. And so we really want to update and especially like spread the word about PrEP, because Black women are disproportionately impacted by HIV and we're not talking about it enough. And it really is a public health threat. And PrEP has been around for more than 11 years. It was approved by the Federal Drug Administration, or FDA, in 2012, and we still have not seen a large uptick, even within the Black community as a whole. And yet, that community is disproportionately impacted when we're talking about same gender loving men, when we're talking about trans women, trans men, as well as cisgender heterosexual men and women. So we really need to be doing more. And where I sit uniquely, I think this dissertation was a venue for me to kind of promote PrEP, but also talk about the disparities we are seeing in the Black community.
I love that research, and it's very important, especially to me as someone who's worked in community health centers where there was a large proportion of patients with HIV or who are transgender, because like, as you mentioned, they are disproportionately acquiring HIV.
Yeah.
And it frustrates me because there were patients who were flying from other states like South Carolina to DC to get PrEP from me because their doctors didn't feel comfortable doing it, or they didn't feel like they were at risk for women. There were some women who said that their doctors said that it was only for men or only for gay men, and that's absolutely not true. So we have to figure out ways to, one, educate the people who are at the front lines, who have the opportunity to give patients, one, if it's safe for them, which is safe for most patients, the medications that they require to protect them from acquiring HIV, as well as educating people who may not even know about it, because we are standing as barriers. It should be a part of the well exam to talk about sexual health, to talk about how they're protecting themselves, to talk about if they need PrEP. Like, personally, I think PrEP should be in the water, but
right.
Conversation. So we have to figure out how to, one, educate the community and the population as a whole to let them know what risk they're at, and if it's up to them if they would like to take PrEP, but also educate the physicians and the nurse practitioners and PAs and people who are at the front lines to bring it up with your patients. Like, it shouldn't be a taboo topic. Like, if you ask them if they're having like cough, you should be like, okay, so how's your sexual health doing? Like, what are you engaging in? Do you have partners who are at risk? Do you have more than one partner? Even if you're married, ask these patients, because we're not testing enough and we're not eliminating PrEP.
Right. And you brought up several points that I want to highlight. So when talking about provider bias, that was one of my findings in my study, is that these women were going to Planned Parenthood and going to vans that would come from University of Maryland School of Medicine that does, routine testing and STI screenings. And those were the first times that they were ever even talked to about PrEP, because they presented with certain symptoms from another STD or STI. And STIs are on the rise. We have antimicrobial resistant gonorrhea, and people should be really in tune with their sexual and reproductive health, and they are not. And specifically when we're talking about the Black community, there is medical mistrust, right? There is mistrust of the government. There is mistrust of providers. And so it takes a very long time for good news and the right news to travel. And rapport being established with providers that look like us is really important. And you talked also about how it doesn't matter if you're an ID doctor or not. We should all be talking and taking sexual history. It's an uncomfortable conversation that needs to be had, because we're not having it. We are having disproportionate impacts on STIs and STDs in specific communities. And then when we talk about this gamut of public health practitioners. Community health workers, patient navigators are key and essential, especially within HIV, because there is something called undetectable equals untransmittable, which is clinically proven and proves that if you are a person living with HIV right now and you are medically adherent and you are virally suppressed, you cannot transmit HIV to another person. And if we did nothing different today and we got everybody that was currently living with HIV on antiretroviral therapies or ARVs and connected to resources and remained in care and virally suppressed, we could actually end the HIV epidemic. But it is because we have lost people following up in care. We have individuals who are living with HIV who are not virally suppressed. We have individuals who have mother to child transmission. We have intravenous drug use and people who inject drugs. We have several different syndemics that are going on within the infectious disease world. And if we continue to work in silos, if we don't have conversations like the ones we're having today, we are going to perpetuate stigma. We are going to continue not bringing new voices to the table for innovative and new practices and expanding this network of we should all be asking these questions when we have patients in front of us. We should provide the data as well as the policies to get individuals like pharmacists to be able to prescribe PrEP or to prescribe PEP and make sure our ED doctors and physicians and nurse care and healthcare staff know about PEP, which is post-exposure prophylaxis. So if somebody is knowingly exposed to HIV, we can stop it within 72 hours. And there are several other tools that are out there to protect those that are HIV negative, but also those that are HIV positive. And I think in the Black community, we really have to start tackling these uncomfortable conversations around sexual health and sex positivity and pleasure and all of these things, because it is a life or death situation. And it is more serious than I think we have discussed in the past, but it's going to take, change, but change takes a while. And behavior change specifically takes a really long time.
I think we should just stop the podcast right now. I wish that I had a little mic to drop for you because you brought up very important topics. Number one, the doctor-patient relationship is one of the most intimate relationships that exist. People tell their doctors more details than they tell their partners, more than they tell their parents and their children. You learn so much about people when there is comfort, respect, and you're acknowledging them, when you don't gaslight what they're saying, when you acknowledge and serve them as a partner. You could learn so much more information. It can help you open your eyes to some of the biases that you may have. It may help the patient share even more. And you should serve as kind of like a person who has an open gate to opportunities, education, lessons, and sharing things that you're learning, which means that you also have to stay abreast of the information that is coming out. As you mentioned, PrEP was approved in 2012, so about 11 years ago. Lots of patients are using it. It's growing. It's saving lives. But some physicians don't know about it, or they will ask in certain groups, hey, does anybody prescribe PrEP? Like, why don't you? Can you read the evidence, read the guidelines, go to a CME and learn how you can serve your population? Know that there are certain barriers for patients coming in to get care. They shouldn't have the barrier of finding a provider who provides basic health care. Number two, you mentioned knowing about all of the different things that can protect a person. Undetectable does equal untransmittable. It's been proven, it's been researched, it's been studied. So we have to stop creating these barriers to get patients into care to be treated. We have to stop perpetuating the stigma of being HIV positive. There are patients out there who are afraid to share the information, which you don't have to share your personal information, but there are patients who are afraid to share it with the doctor when you get tests. And then they're like, oh, yeah, I knew that. Why didn't you say it? Like, there could be some form of decrease in shame. I recently wrote an article for Kevin MD that should be out, if it's not out yet, soon. But it talks about how the Little Mermaid movie came out recently.
Yes.
I love the Little Mermaid. And it was actually my favorite Disney movie. So I kind of ran down this rabbit hole one night on YouTube. You know how it goes. I was watching it, and then I was watching the original sing it, then I was watching Haley Bailey sing it. And it got to like, who wrote these lyrics? And I found out about the lyricist for the Disney Renaissance and how Howard Ashman is the person. He was writing plays, and he transitioned to The Little Mermaid, was his first movie, becoming a lyricist for. And he ended up writing for Beauty and the Beast and Aladdin. But while they were filming The Little Mermaid, he was diagnosed with HIV. And this was in 1989. So he continued to keep it a secret. He originally didn't want to get tested, even though he knew one of his partners had died from AIDS. And he was like, I'm going to lose my health insurance, like from Disney, or people aren't going to work with me, and things like that. So, of course, it progressed. He started telling people once he got sicker. They ended up actually filming like a lot of the recordings and stuff for Beauty and the Beast from his house. And he wrote like Aladdin, like one of the songs, like while he was in his hospital bed dying. So he actually passed away before the movie came out in 1991. Wow. So the reason that I'm telling you about this is because that was in 1991. It is 2023. Why do we have the same stigma going around? Why are we so misinformed about HIV? And at that time period, unfortunately, there weren't all of this advanced treatment. There wasn't ART. People didn't know how to be treated. It was a death sentence.
Right.
You just mentioned that people who are being treated by HIV do not have to have a death sentence. It is like another disease now, like being diagnosed with diabetes and hypertension. Now, of course, people don't want to acquire HIV. So we have things like PrEP. We have things like condoms. We have all of these advances out there. But for people who are living with this disease, they should, one, be respected. They should, two, have open availability to treatment. And their partners should be protected from acquiring the disease. Now, all of that is available, and every single living provider and public health official should be singing that to the top of their lungs and broadcasting it worldwide. So where are we going to go from now? My rant is over.
Right. No, but two things you said. So one, what you're talking about is a status neutral approach. And we at the federal level have been pushing a status neutral approach, which basically is within the continuum of care. No matter if you're positive or a negative status of HIV, you are going to get connected to resources despite whatever symptoms you arrive with. And the biggest part of this status neutral approach is really capturing those that are HIV negative and for them to remain negative, but also breaking down barriers and breaking down stigma. You also talked about bias, which I think is something that is a larger conversation that we would need a whole podcast for that.
We will definitely invite you back to the show and talk all about bias. But moving back the conversation to the students, there may be students like we talked about who are interested in infectious disease, who are interested in getting an MPH with their MD, who are very dedicated to eradicating the HIV/AIDS epidemic. But there are also students who, of course, will stand on the front lines and things like that, because all people who are in medicine are basically warriors against the HIV epidemic. So how would you recommend students work at this point in time, if they're in school or if they're pre-meds, to be impactful, even if they don't choose to go through the infectious disease route?
So there's several things that individuals can do, and advocacy is a first great way to start, even educating yourself. So one of the websites we have within my office is hiv.gov. hiv.gov has a blog post. There are several different entities on the website where you can learn about awareness days. You can learn about different initiatives that we have at the federal level. And then also CDC.gov has a lot of different ways that you can get involved and learn more about HIV, as well as other infectious diseases, as well as STIs. Right now, a really big word is syndemics, which basically means that we're taking factors outside of an individual, like social determinants of health, like education, where you work, where you live, play, all of those things are structural determinants of health. And we're combining that with lived experiences. And if those things are happening simultaneously, something like COVID-19 and Mpox, for example, how we address both of those is not going to be a one size fits all approach. So therefore, we need a syndemic approach that is going to address what's going on with Mpox and what is also going on with COVID-19 and making sure they all communicate together. So syndemics are something that are happening all of the time, and they are not new, but they are recently highlighted within this realm of doing social justice, health equity. And so when thinking about where you see yourself in the field, if infectious disease is something that you're interested in, educating yourself is the first step. Figuring out what levels of advocacy that you can participate in is great. If you know somebody that is living with HIV, or you know somebody that has dealt with an STI, talking to them about their experiences, figuring out what could have been done better, what can we continue to do better, and how can you advocate for better healthcare or access or education is a great start. Additionally, like you said at the top of the podcast, if you are interested in medicine or becoming a clinician of some sort, explore all the things that are outside of that first, because the clinician road is long, right? And we know that there are certain classes that you can take, or maybe tracks that you can go on, or different minors or different certificates that you can get. So while you are educating yourself on this pre-med track, take that HIV epidemiology course, take that public health surveillance course, take the GIS mapping course, take that economics course that you've been looking at, take that political science or that health justice, that social justice class that really piqued your interest. Figure out where those niches are, because that's going to set you apart as an applicant as well. And I love telling my mentees that we are all unique individuals and we all have a role to play. So you trying to fit into a box or trying to emulate somebody who has come before you is not going to work, because that's not authentic. You need to figure out what is authentic and unique to you, and why you've been brought to this field of medicine, why you've been brought to the field of science, or why you've been brought to the field of research. And how do you want to make a change? Do you want to break down barriers of medical mistrust? Do you want to become a TikTok star that breaks down racial and ethnic health disparities to a level that a middle schooler or an elementary schooler could understand it? You know, there's all these different ways that we can also educate our populations that we're trying to impact change. And that's why I wanted to go into public health, because I wanted to think of larger than just the patient provider relationship. I wanted to create change for populations of people. And I think for the most part, we go into medicine because we want to help others, and we go into public health because we want to see the world better than we found it and promote health and well-being. And so if you're in this field and you know you're passionate about something, hold on to that, and it will take you to new heights that you didn't even know existed. But infectious disease is just one of the very vast fields that are out there that are disproportionately impacting people that look like you.
Absolutely. Now, I just want to point out 3 things that you said. Number 1, look into your resources. There are lovely resources in the ones that you mentioned. I will also mention in terms of advocacy. I know when I was in medical school, we had Greater Than AIDS, which is still around, the campaign where you can go and you can educate people. You can get your classes together, your interest groups, your student organizations, and kind of push the envelope in showcasing how to utilize some of those campaigns so that you can be a part of the advocacy and the mission. The other part about just finding your purpose and exploring other things, especially if you're still in college. I will say a lot of people do the traditional pre-med biochemistry major, but There are so many other majors out there, and you don't have to be a science major to become a physician. I actually would encourage you to explore some of those other interests, because when you're in medical school, that's your curriculum. So you come in as a freshman or a sophomore, you decide you want to be pre-med, be that English major, go and study political science, social justice, all of those things, and just meet with the pre-med advisors so that you can make sure that you have your core curriculum that will help you maintain the requirements to matriculate into medical school. And then the third thing, like meeting patients where they are. Like you said, it's okay. Patients aren't necessarily searching the official government documents or reading the after visit summaries of their doctors. Like, we're kind of have it right now kind of way. So we have to bombard these social media places, the YouTubes, the TikToks, the Instagrams, all the new ones out there, and share reputable, evidence-based information. So you guys are learning that now. So share what you've learned in an easily digestible manner that meets people at their health literacy levels. You could probably make a large difference.
Yep. And meeting people where they are is like a life theme, because specifically we do this work not because it's glorious, but because we want to make a difference. And meeting people where they are is a way to do that and is the best approach. And bringing evidence-based information and breaking it down so that your grandmother could understand it, who has no idea what is up to date on, the world of medicine and science, or talking to your little sister or your little brother or an older adult who might not be well versed and able to understand some of the science rhetoric. It's really important as a practitioner that we understand how to break down things to a middle school reading level. And when we do that, we are able to effectively communicate. And so if you can talk and do a grand rounds, and you can have the medical and scientific rhetoric, and you can also go to a elementary school and do an assembly and talk to them about, being protective and wearing masks for COVID, you are a great practitioner, because it's not only code switching from an academic lens, which is, a whole nother thing. It could be a whole nother podcast, but being able to effectively communicate as a leader is something that you want to learn how to do early on. Because as you get older, you will have different groups that you need to speak with. You'll have different populations that you need to impact change on. And if you're able to effectively communicate and lead with this thing called cultural humility of, again, meeting people where they are, breaking it down so they understand it, you will go so much further than the typical practitioner that's out.
Couldn't have said it better myself. You have shared so many pearls of wisdom with us today. We really appreciate you coming on the podcast. I just want to give you an opportunity to say goodbye to the listeners, as well as let them know how they can reach out to you if they have questions.
Sure. So thank you again, Erkeda, for even reaching out to me to be on the podcast. Always love, speaking for and by communities of color, first and foremost, because I'm rooting for everybody Black, as Issa Rae always says. I say that every time I present, and anything that I do, I'm always representing for us. If folks want to get in contact with me, please, please, please find me on LinkedIn. Also, if you want to email me to get more nerdy in the epidemiology or talk more about infectious disease or my matriculation into this wild ride of public health, you can email me at drmarissarob@gmail.com, Dr. Marissa Rob @gmail.com. I also have Twitter. So if you want to follow me, Dr. Marissa Rob, please follow me on Twitter and just stay in touch. I'm always looking for mentees, helping students to apply to graduate schools or even talk about, what they're passionate about and help with coaching. So if that's something that you're interested in, please, please, please don't hesitate to reach out. Don't be a stranger. And again, be well, stay safe, and keep doing what you're doing, because you're doing a great job.
Thank you so much. And for all of the listeners out there, definitely let us know what you want to hear about on our upcoming episodes. So let me know the topics, if there are people, if you want to be highlighted, just let us know. Click that subscribe button wherever podcasts are found. We now have a YouTube channel. So if you're listening to this on your podcast you might want to go and type in the Prospective Doctor on YouTube and check us out in our facial expressions. So definitely reach out to me at Dr. DeGram, DOCTOR, the letter DGRAM on Instagram, or you can reach out to Med School Coach at Med School Coach and let us know what's up next. See you next week with another fantastic guest. Bye.
Bye.
Each episode of the Prospective Doctor podcast is brought to you by Med School Coach. To access articles, videos, webinars, and free tools to help you succeed on your journey toward medical school and beyond, visit our website, prospectivedoctor.com. We hope you tune in again next time.